Dr. Brian Quinn, welcome to Shrink Wrap Radio.
Well, thank you so much for having me, David. I appreciate it.
Well, I'm really glad to be speaking with you today. And we're going to be talking about some of the complexities around the diagnosis and treatment of depression and its various forms. But before we get into that, tell us a bit about your background and how you became interested in depression.
Sure. Well, I'm a clinical social worker by trade, been in the field for 40 plus years. And back in the late 80s and early 90s, when Prozac and its cousin medications first came out, a lot of people I was seeing in private practice were not on medications. And then during the 90s, many people started to come into my office who were on these medications. And after about 5 or 10 years, towards the late 90s, I noticed that in spite of the hype, a lot of people weren't doing very well on these medications. In fact, some of them had been on 2, 3, or 4 different of the SRIs, and they just were not doing well. And in fact, some of them were doing horribly. So I did some research, and I found out one of the main reasons was that many of these people did not have simple depression. They had some variation of bipolar depression or bipolar spectrum illness. And it was from there I kind of got more deeply into working with people with depression and bipolar illness and doing differential diagnosis for that.
And I remember when Prozac first came out, and somebody wrote a book that was very popular that a lot of people read.
Yes, Kramer, Listening to Prozac.
Yeah. And so I think it got a lot of people, it was presented almost as some kind of a miracle drug. And I think a lot of people were just drawn to it. Maybe they didn't even have a diagnosis. I don't know if it became it wasn't a party drug, but it became something that people were drawn to exploring.
Yes, well, it and its cousins like sertraline and paroxetine and all those following Me Too drugs, they became very widely prescribed for anyone with symptoms of depression and anxiety, to the point now where antidepressants are the most widely prescribed class of drugs in the United States. And unfortunately, the art of differential diagnosis seems to have gotten lost. You know, the physicians have an expression. They say all that wheezes is not asthma, because wheezing can occur in, it can occur if someone has congestive heart failure, for instance. Similarly, everyone who is depressed does not simply have major depressive disorder. The need to do a differential diagnosis, realizing that depression is a constellation of symptoms. It's not a diagnosis, and it can occur in many different illnesses. And this seems to have gotten lost over the last few decades, the need to do a differential diagnosis. And this sort of knee-jerk reaction many prescribers have for anyone with symptoms of depression. They have depression, give them an antidepressant.
I want to highlight what you just said about depression is not a diagnosis. Tell us a little bit more about that.
Well, again, depression is a constellation of symptoms that can occur in many different illnesses. It's non-specific. For instance, if you go to your physician with a cough, he doesn't say you have a cough disorder. He takes some time to try to figure out, is the cough due to bronchitis, pneumonia, asthma, some lung irritant? In a similar fashion, anxiety and depression are non-specific. They occur in many different disorders. And it's often not well appreciated that bipolar illness is a largely depressive illness. And if you don't look carefully at the course of the illness, age of onset, occurrence of episodes of hypomania, if you don't look at family history, you're going to make the mistake of diagnosing depression on the basis of cross-sectional symptoms.
Yeah. I don't know that anybody made that distinction when long ago, when I was in graduate school. I think depression would have been considered a diagnostic disorder in and of itself. Certainly I had that impression. And I remember we learned about manic depressive illness. Is bipolar, in fact, synonymous with manic depression, or are there new wrinkles?
Not really. Another thing that's often not well appreciated is that before DSM-3 in 1980, manic depressive illness included highly recurrent depressions and people with manic symptoms. It was all part of one thing. It was only in 1980, based on some data at the time, that psychiatrists split up unipolar depression, calling it major depressive disorder, and bipolar, to the point where now we think that people who just have with just a history of depression without mania have a different illness than those people who've had both depression and mania. And the best scientific research, based mainly on Jules Angst's work, the Zurich cohort, he's been following these people over 40, 50 years, indicates that's not the case. It's very, very hard to distinguish these two illnesses.
Yeah, interesting. And I want to just put in a little orientation note here that potentially we have two audiences that we're speaking to in this interview. One is going to be people in the mental health profession, and the other, to some proportion, probably are people who suffer from either depression or bipolar, who are looking for resources, trying to understand what's going on with them. So that might be something for us to keep in mind, as we go along.
Okay, for sure, I will. To those who are not mental health professionals, who are patients or family members of patients, I think the take-home point here that's so important is that if you or you have a loved one who's been on 2-3 different antidepressants in combinations with other medications, and they're not getting well and they're not staying well, one of the main things you need to look at is, do they have simple depression? Very often they don't. They usually will have some form of bipolar spectrum illness. Now, of course, there are other possibilities, substance abuse, medical illnesses like thyroid, but one of the main reasons why people don't do well on multiple antidepressants combined with other drugs, I mean, I see this in my practice all the time. It's kind of what I've evolved into. One of the main reasons is undiagnosed bipolar illness. And the current science, David, that people need to know is that even though antidepressants are the most widely prescribed class of drugs for bipolar illness, the science, the research does not support that. In fact, it shows that antidepressants are the wrong treatment for people with bipolar depression.
Before we go deeper into bipolar, you said simple depression. And for people who are deeply depressed, though, it doesn't feel simple. So let's talk about depression a bit, but not my favorite subject.
Sure. Well, when I say simple depression, I'm trying to make a distinction between people who have what we could call unipolar depression, or the absence of the family genetics for manic depressive illness or bipolar illness, and who have not had a manic or hypomanic episode and who are not likely to have one. In other words, people who just have the genetics for the depressive pole of the illness, as opposed to people who, especially young people, early age of onset of depression, as a risk factor for the later development of bipolar illness. So it contrasts simple depression, plain depression, versus people who have some version of bipolar illness or manic depressive illness.
Okay, so there is a genetic component to depression, to a plain depression?
There is a modest genetic component to unipolar depression. About 30 to 40% of the variance is genetic, whereas in bipolar illness, it's virtually entirely genetic. Upwards of 80% of the variance is genetic.
Yeah, I'm going to want to dig down into that. And I think maybe this is the time to start doing that. I remember when I was in graduate school, somehow this little I also taught abnormal for many years at the university. And I don't remember if this is what I learned from as a graduate student in clinical psychology, or if I learned it from my teaching out of a book at some point. But I recall that it seemed like there would be a higher incident among in the male line of manic depressive illness. Is that the case? Has subsequent research supported a gender bias?
I'm not sure that is held up. Women tend to have a higher rate of bipolar 2 illness, which is hypomania and depression, whereas men tend to have a higher rate of bipolar 1, which is the history of mania and depression. But the key feature really to distinguish these is, well, there's a couple of them. One is a very early age of onset of depression. In other words, what we know is from the research is that the onset of depression in childhood, adolescence, or young adulthood up to the age of 25 is a robust marker for people who will later go on to have a manic episode. According to DSM, you can't be considered bipolar unless you've had a manic episode. But about 70% of people start off their illness with a depressive episode. So that's really a key feature, perhaps more than gender, is an early age of onset of depression, along with a very dense family history of mood illness, perhaps bipolar, but depression, bad tempers. You combine that with non-response or poor sustained response to multiple antidepressants, then you start getting at the criteria. So you got to look at not just the symptoms, family history, response to meds, and age of onset.
Well, getting at the age thing, I don't think we used to be as aware maybe as we are today of children at young ages getting depressed.
No.
Is that a relatively new thing, or just we didn't know to look for it and to diagnose it?
Well, there was a time, maybe a couple of decades ago, where it was considered that children really didn't have the psychological or psychic structure to be able to develop depression. Well, all you need to do is go to a child psychiatry clinic and find out that kids can certainly be depressed, and sometimes profoundly and suicidally so. That's kind of gone out the window. And it used to be thought that, it's now known that the average age of onset of plain depression or simple depression or unipolar depression is in the late 20s. An age of onset in the teens or before of depression, again, is a marker for bipolar depression. So kids, adolescents, and young adults, especially with severe suicidal depression, must be worked up for the possibility of bipolar depression. It's not diagnostic, but the younger the age of onset, the more likely the person will eventually have a manic episode. And as it turns out, the data is onset of depression in the teen years. You follow them out over 15 years, 40 to 50% of them will eventually have a manic episode. Or hypomanic.
Yeah, episode. That's fascinating. Now, what about antidepressants and suicide? I think antidepressants are routinely prescribed, as you said, when people come in complaining of depression. What's the relationship to eventual suicide? Do
Well,
antidepressants help people not to be suicidal?
antidepressants, if you look at the best research, it's sort of a wash. As we know, there's antidepressants have this black box warning for the last the last 10 years, black box warning for increased risk of suicide in children, adolescents, and young adults. And one of the major reasons for that is that these youngsters have a form of agitated or mixed depression. It's actually in the bipolar spectrum that confers an increased risk of suicide. In fact, antidepressants prevent suicide to some extent, but also increase the risk, and it's about a wash. What's not appreciated is that there is one drug out there that profoundly decreases the risk of completed suicide. And it's been around for 60, 70 years. And it does so at low doses that don't produce side effects, and that's lithium. Lithium reduces suicide by about 90%. Antidepressants don't hold a candle to lithium in terms of suicide prevention. And this has been repeatedly demonstrated over decades by independent researchers in randomized controlled trials showing that lithium is profoundly anti-suicidal.
And I've only heard of lithium in the context of manic depressive illness.
Right. Unfortunately, yeah, and people tend to be very scared when they hear about lithium. They think, well, it means I'm crazy. It doesn't. Lithium not only prevents suicide, it is neuroprotective and is being studied as a treatment or a prevention for Alzheimer's disease. It reduces all-cause mortality and mood illnesses by a factor of, by 10 years. People live 10 years longer on it. And it is the most effective drug for preventing depressive relapse, whether it's someone who's bipolar or unipolar. So it's probably the most effective drug in psychiatry. It's just that a lot of people have a tremendous fear of it because of its association with, profound craziness.
Wow, yeah, there ought to be a plane flying in the sky, with a big banner behind it. Lithium thing, consider lithium.
And you know why it isn't is because no pharmaceutical company can make money off it. It's an element. It's an element in the periodic chart, right near sodium.
Yeah.
And no one can make tons of money off of it. You'll see banners for Latuda and antidepressants, but not for lithium.
Yeah. Wow, that is really, really fascinating. And in another interview, I heard you talk about the importance of psychomotor slowing versus psychomotor excitation. Right. And give us the context for that. That sounded like an important diagnostic consideration.
It is. Depression has classically been considered psychomotor slowing. People are slowed down, they're lethargic, they're unmotivated, they don't feel like doing anything, they're thinking slowly. And mania is classically been considered psychomotor excitation. People's mood is either euphoric or incredibly irritable. They're thinking fast, they're talking fast, they're doing a lot of things. Now, bipolar illness or manic depressive illness has classically been thought of as the alternation between periods of depression and mania. But the research shows that actually most mood episodes are of the mixed variety. That is, they contain elements of psychomotor slowing, but psychomotor excitation at the same time. So for instance, in practice, people will come in saying, I'm depressed, I'm unmotivated, but they'll have trouble getting to sleep at night because their thoughts are racing, they're agitated, and they're irritable. Mm-hmm. And this does have a profound clinical implication, which is that antidepressants are especially ineffective for these mixed depressive episodes and can actually make them worse. One study showed that antidepressants in people with mixed depression, depression with some elements of psychomotor excitation or mania, are 2.5 times more likely to attempt suicide as people with mixed depression who are not treated with antidepressants. And I see this regularly in my practice. People come in, they've been on 2, 3, 4 different antidepressants. They're agitated, they're anxious, they're still depressed in spite of the antidepressants. And what prescribers don't think about doing is they don't think about stopping the antidepressants and using drugs that are specifically useful for mixed depression. And that's very important with bipolar disorder people or people with mixed depression. It's not just adding medications, it's stopping ones like antidepressants.
So do you have a relationship with one or more MDs who understand these facts that you can, get to work with you on the cases that you're seeing?
Well, it's a very important question. And the answer is, yeah, probably 1 or 2. It's unfortunate, but these science-based diagnostic and treatment facts that I'm talking about are not widely known among prescribers. And this is in the literature. There was a study done just last year showing that antidepressant use has increased by about half in people with bipolar illness, in spite of the science showing that antidepressants are ineffective in this group and can make them worse. And unfortunately, it's very hard to find psychiatrists and nurse practitioners who are aware of this science.
Wow.
So it becomes very frustrating for psychotherapists who work with mood disorder patients to find prescribers who know this stuff.
Yeah, I would think so, particularly when you have sales reps calling on them regularly,
Yes.
with
Yes.
inviting them to dinners and various other sorts of perks that the drug companies offer to physicians. I can imagine that you run into considerable resistance.
Yeah, it's funny you mentioned that. When I do these do webinars on this topic, you have to declare whether you have any conflicts of interest.
Yeah.
And I always say, no, I've tried to develop some, but since I don't prescribe medications, no one will give me anything. No, I don't get any pencils, pens, or free lunches.
Right.
Whereas, pharmaceutical reps will come around and push the latest antidepressant. Very few people are coming around and urging people to come off of antidepressants and go on lithium.
Yeah. Wow. I think that's just a big part of the story here that we're talking about. I have a personal interest in bipolar, actually, because I believe there's a genetic component in my paternal family line. And I'm not totally clear on all the details because I didn't grow up with my biological father and didn't discover him and be able to speak to him until I was in my 30s.
Oh.
And one of the things that I found out was that he had been hospitalized for I don't know if it was for a manic depressive episode. I suspect it was for a depressive episode at Langley Porter Neuropsychiatric Institute, which I think is connected with the UC Med Center or something like that here in California, Northern California. And I think some of the content of it, well, he was a writer. And I know one of the things that you've observed is that there's a high percentage of creative talent among people who suffer from bipolar.
Yes.
So he
Yes.
was, yeah, go
Yeah,
ahead.
it's very interesting. Uh, when clinicians are doing evaluations of family histories, of course you want to look for uh, things like this. Are there indications of severe mental illness? A generation or two ago, of course, people were not, these things were kept secret and they weren't diagnosed. But if you see a family history of people with psychiatric hospitalizations, electroconvulsive therapy, this should raise a clinician's index of suspicion for bipolar illness. But the other thing that you just put your finger on that's really fascinating is the good side of this. Manic depressive illness confers creativity, risk taking, oftentimes very, very considerable interpersonal charm and social skills. So in the family histories of people with mood illness, you always want to look for, are there writers, artists, musicians, people with performing arts talents? Because in the family histories of people with bipolar illness, there's a much higher rate of this kind of creative talent than there is in the general population.
Yeah.
And I see this in my practice all the time. And it's not surprising to hear that on your paternal side, you had someone with severe mental illness who was hospitalized, but also had this writing talent. This is a very common finding in my experience, and it's borne out in the research as well.
What I heard as part of the content of his of this episode was a lot of anxiety on his part that he hadn't lived up to his full creative potential.
Mm.
And then when he got over this episode and was no longer hospitalized, actually, he went on tour. He had been connected to Woody Guthrie, the famous American folk singer. And so he went on a tour doing, talking about his days and experiences with Woody, and doing it with a guitarist and a singer and, putting on this show. So he put on a show. And he'd also, in his early years, he had been associated with a lot of people in Hollywood and so on.
Fascinating.
And was a very charming person, as you described. And I have to say, people would describe me as a charming person if they meet me at the right time, the right circumstances.
Yeah. And again, these traits, these adaptive positive traits, run in families as much as the negative psychopathology does.
That's
some of the greatest artists, composers, and writers in Western civilization have had bipolar illness. I'm just reading now Ernest Hemingway's book, For Whom the Bell Tolls. Ernest Hemingway had bipolar illness, was alcoholic, and he committed suicide. His father committed suicide. He had ECT. His siblings committed suicide. His granddaughter committed suicide. So there's this. We don't want to romanticize this too much, but manic depressive illness does confer some very positive adaptive traits, along with all the pain and suffering it causes.
That was one of the things I wanted to explore with you. And before I go there more, I just want to let you know that his father, I was told, I never met this grandfather, don't know much about him, but that I was told he died in a mental hospital. And it was manic depressive, I think is what I was told. And we hear about hypomania. Is there such a thing as hypermania? Is that what would land person in a mental hospital?
Well, everyone thinks that to be bipolar, you have to have mania. I have had a lot of people come into my practice saying, well, geez, what do you mean? How can I be bipolar? I've never had manic episodes. But you can have had hypomanic episodes, which is below mania. People who are hypomanic are not obviously ill, and they get a lot done. They're full of energy. They don't need much sleep. And they're often very charming, risk takers. They can have a very bad temper, however. But you also put your finger on another concept, not mania, not hypomania, but a mood temperament that's chronic and long lasting is called hyperthymia, hyperthymic temperament. These are people who are blessed since childhood and adolescence with high energy, very sociable, outgoing, risk takers, habitually short sleepers, and they're often very successful people. And it's a very common mood temperament among those with artistic talent. And oftentimes why this is clinically important is, and it's often overlooked, if you have someone, particularly a young adult who comes in who's depressed, you always need to look at what was their temperament like before the acute episode of depression. Very often you will see people with these chronic high energy temperaments. Sometimes they'll also have cyclothymia, where they go up and down prior to their more profound and clear-cut depressive episode. Now, people with hyperthymia usually don't get hospitalized. If your grandfather was hospitalized, chances are he may have had a hyperthymic temperament out of which grew a manic episode or a depressive episode. This is very, very common. Hyperthymia, cyclothymia are the fertile temperamental grounds out of which later more clear-cut mood episodes emerge.
Well, I was told he died in this mental hospital, and so this is a hospital that's no longer open, and because a lot of hospitals were closed and people were sent out into the community, and when you got into one of those kind of hospitals, it could be very hard to get out, right?
Well,
once you had some kind of heavy duty diagnosis.
Well, particularly back then, there were very few treatments available several generations ago. They had electroshock therapy in the 30s. Lithium became used in the 40s and the 50s in Europe, not till the 70s in the United States. So oftentimes people got with manic depressive illness were hospitalized chronically or in perpetuity because they could never get them well. That was part of the problem. So
knowing what I did about this background and being under the impression that it was particularly traveling in the male line, which may have been a misunderstanding on my part, but I have 3 sons now, all adults, doing very well. And but I sat them down in early adulthood, and I'd seen them get depressed or down about one thing or another, as every human being, I think, goes through some periods of blues, etc. But I sat them down and I said, look, there is this genetic thing in our male line, and you need to know about it so that you can know that the wheel will keep turning, that if you get down, you get super depressed, you're going to come back up. And so you need to ride it out, is basically was my paternal message to them.
Right. Well, that's a good message, because very often when people get depressed, it feels like it's going to be that way forever.
Right.
One of the reasons that when I started in my training back in the 70s, that when I did my training in a psychiatric clinic, the supervisors wisely gave all the social work interns the depressed patients. Why? Because depression, the average depressive episode, bipolar actually is quicker, but the average depressive episode lasts 6 to 12 months. How long is the internship? Well, it's 9 months. At the end of the 9 months, everyone was getting better just because of the
You
natural
could feel
history of the illness.
successful.
Right. The only problem is that, and this is often overlooked as well, is we should be a little less concerned about treating the acute episode and more worried about recurrent episodes, because that's the nature of the beast. Is these are highly recurrent episodes.
Having disclosed a lot personally already, I'll go a little further. Is I have had 2 episodes that I would say are on the heading towards the hypomania that you're talking about. Both were a result, aside from whatever genetic background there is, both were a result of being put on a medication. The
Steroid?
first, huh?
A steroid medication?
That was the second one. Yes, was a steroid. The first instance was Valium. I had some kind of stomach disorder. I don't remember what it was, but they thought Valium might help calm my system. And so I was taking it chronically, that is over, and it was a low dose. I think it was like 5 milligrams or something like that, that I took for some long period of time. But then gradually I began to, I was a fan of pocket watches and the sort of historical significance of, having a pocket watch. And then I got this idea that most pants don't have a watch pocket anymore. And so I thought I would invent a portable watch pocket. And I got somebody to make a prototype for me, and I was talking about it all the time and talking up this idea that I thought was, I thought it was going to be great. And I think my wife has been a stabilizing influence in my life. And sure. I think she kind of recognized at some point there that I needed to calm down and back off of that. So somehow that happened, that backed off. More recently, I was put on prednisone by my GP for as the first trial to figure out why I was having itching patches all over my body. It turned out to be something very different, but he thought, let's give prednisone a try. And gradually over time, I was becoming a poet. I had not written poetry before, other than haiku and dream classes that I taught. And I would kind of use that poetry as a little device. But then I started writing poetry about family history stuff. And it seemed like it was really good to me. It seemed like it was really meaningful. Ran it by family members and other people, and they said, "Oh yeah, this is poetry." But I began to. I've always been a good sleeper, and I was waking up in the middle of the night and having to go write these things down. I would try to rehearse it in my mind while I was asleep, or I would tell somebody about it in my dream, and be sure to tell me about this tomorrow when you see me. And of course, that didn't happen. And at some point, I began to realize, okay, this is going off the deep end here. And so I stopped taking the prednisone. And I had hoped that I would continue to write poetry, but the energy just hasn't been there to do it, the drive to do it.
But you see, what happened was, you mentioned that, was it your father or grandfather had a talent for writing?
Yeah.
And when you took the prednisone, neuroactive steroids like that can produce, well, they can do it in someone who doesn't have the genetics for bipolar illness, but if you have them, those neuroactive steroids like prednisone can precipitate a hypomanic episode. And if it's not too bad, it'll help you tap into those creative talents that are there. And that's what happened. It's just that what marks it as hypomania is probably is you started to wake up in the middle of the night and do this stuff.
Yeah.
So I've seen quite a few people in my practice, middle-aged and older, who use neuroactive steroids, who've developed the first-time hypomanic or manic episode. And you look back, and they all have that family history of some sort of markers for mood illness and usually creative talent.
Yeah, I wish that there were a drug out there that I could safely take that would put me in that same place.
Right.
But that, could be moderated. Fortunately, right. I was, smart enough to realize, okay, I need to moderate this, and this is getting out of control. And
right.
Nobody else told me that, but I just knew, I am a
right.
psychologist. And so
right.
but I was glad that you talked about the positive aspects of this, because it raised in my mind something that I wanted to ask you about, which I think you've already really spoken to, which is, are there degrees of hypomania, and are there positive ways of adapting to it and making use of it? And I'm thinking of things maybe like, well, they're acting out possibilities, probably,
right.
maybe extramarital affairs and all sorts of things like that, maybe drug use.
Yes.
So,
well, if you look at the diagnostic criteria for hypomania and mania, one of them is a high potential. There's a tendency to become involved in pleasurable activities that have a high potential for negative outcomes. And they are sexual indiscretions, foolish business ventures, impulsive travel, and overly aggressive driving. But again, we have to keep in mind that some of the greatest artists, composers, and musicians in Western civilization have had these mood episodes. And it does confer periods of great productivity and creativity, but often combined with periods of no productivity or creativity and profound suicidal depression.
Yeah.
So that's the dark side of it, is that what goes up must come down, unfortunately.
Yeah, I've definitely used that phrase many times. Had to recognize that, partly because in the 60s I got involved with, there's been a lot of high risk taking in my history, hopping freight trains, jumping out of airplanes for a short time with a parachute, becoming a glider pilot,
there you go,
motorcyclist, so all that kind of stuff.
Yes, and it's all a piece of the same puzzle.
And then psychedelic drugs, and the psychedelic drugs, the backside for me was always deep depression, and so I finally just had to stop, because while the highs were good, the backside, I really had a direct experience of it, and just energetically, that you could have a lot of energy, and excitement from a psychedelic high.
Yes.
But I could feel the physical costs in my body the next day of just no energy, and as well as the depressive thoughts as it began to come down.
Well, that's the problem, is it can produce, in the vulnerable individual, you can increase cycling, and in fact, antidepressants can do that as well in people with bipolar spectrum illnesses. They can actually increase cycling and actually produce more depressive episodes than would occur naturally in the history of the illness. So here's what if I can sort of pull some of this together, what I tend to see in my practice is this: a young person, somewhere between the ages of 18 or 22, maybe a little bit older, they're referred to me because they've been on 2 or 3 antidepressants. They're not doing well. or maybe they got better and then they got worse. And they've been tried on these different antidepressants. In the family history, there are people who've had psychiatric hospitalizations, ECT, but often people with musical and artistic talent. And very often the young person sitting in front of me has some artistic or musical talent. So they had an onset of suicidal depression at an early age with a family history, clear family history of severe mood illness and increased cycling and non-response to multiple antidepressants. And everyone's sort of scratching their head about why isn't this person getting better? And and they'll never get better as long as they stay on antidepressants.
Yeah.
And one of the reasons I got into this is I found doing effective psychotherapy with people who are in the bipolar spectrum who are on antidepressants is virtually impossible. You can be an excellent therapist, but if someone's course of illness is being made worse by the medication, it's going to be very, very hard. So what I've found is when I find a prescriber I can work with, we get the person off of antidepressants onto mood stabilizing drugs or atypical antipsychotics. Some of them are appropriate as well. And these people do very, very well. And then effective psychotherapy becomes possible as well.
Yeah, you point out that effective psychotherapy can take a long time and require a lot of work over a span of years.
Yes.
And,
but it can take less time and the person will get better if they get off of antidepressants.
right.
That's really the key. It's not just getting on lithium or Depakote or Tegretol or Latuda. It's about getting on those mood stabilizing drugs and then getting the hell off of the antidepressants.
I want to touch on, I don't know if you're up on the literature on psychedelic-assisted psychotherapy, particularly ketamine is being used for depression.
Yes, I'm familiar with the literature, and there are 2 points about ketamine and other drugs, psychedelic-assisted therapy, or even just ketamine in the right doses, can have a very, very rapid antidepressant, anti-suicidal effect. There's some indication that this may be less so of a case with people with bipolar depression, but because I've seen people in my practice who've been on ketamine who haven't done well and haven't responded to it, and they've all been in the bipolar spectrum.
Uh-huh.
But there is some research on the use of ketamine with bipolar depression. But here's the thing that no one ever stops to consider. You have to think beyond acute treatment of the depressive episode to long-term stabilization. And no matter how effective ketamine may be acutely, or transcranial magnetic stimulation. I've seen a lot of people who've had that.
Oh, really?
No matter how effective that is acutely, there is no research showing that those treatments, ketamine, transcranial magnetic stimulation, produce long-term stability. And that is they prevent recurrent episodes of depression and hypomania. And that's really where all the business lies with treating these people. It's not just treatment of acute depression, it's long-term stability. And these drugs like ketamine, not only is there no evidence they produce long-term stability, there's growing evidence that they may produce instability over the long run, even if they are acutely effective.
Yeah, that's a story that's yet to be, this cultural phenomenon that's happening right now with a lot of enthusiasm about this. And I've interviewed a number of practitioners of the psychedelic-assisted therapy variety. Yes. And they all try to build into their sessions, which tend to be short term, maybe a 3-day session or one for a number of weeks, small number of weeks, they have come to focus on integration. How does the insights that the person has had, how do they get integrated into their lives, and to look at, things that will support that continuing. So I think the caution that you raise here is a legitimate one. And I think people are experimenting nonetheless, and we'll see with time and hopefully with good research.
Yeah, and
what works and what doesn't.
People usually turn to ketamine and transcranial magnetic stimulation when they've had repeated episodes of depression that are not responding to standard antidepressants. And unfortunately, the therapist and the prescriber of the ketamine are still locked in the same paradigm of depressive symptoms equals a diagnosis of depression. Therefore, we must give an antidepressant treatment. If someone is not responded to standard treatments for depression or keeps relapsing, before you go to ketamine or transcranial magnetic stimulation, you have to go back and rethink the diagnosis, that the diagnosis may not be simple unipolar depression.
Right.
That's the thing I hope your listeners take home from this is, don't make the mistake of going from symptoms of depression to diagnosis of depression to thinking that, well, what's on the list of antidepressant treatments? You really need to think that the diagnosis through. You need to do differential diagnosis.
Well, I want to close off our discussion with a general question, which has to do with the fact that we're living in a pretty depressing time.
Yes.
And how are people, we're looking at pandemic, climate change, extreme political polarization,
Yes.
On a wide scale, all of these things. How's a person to cope with all that? And I suppose that could help to trigger maybe, some deeper lasting kind of depression.
Well, look, I think the important distinction here is to make the distinction between depression in the everyday sense of the word, in the existential sense of the word, in the sense of being a human being in a complex and troubled world, versus depression that is an illness. All of these modern factors in someone who has the genetic vulnerability they should be viewed as triggers for a depressive episode, not as the cause. However, in the differential diagnosis of depression, we have to keep in mind that some people become profoundly depressed, demoralized, discouraged, adrift in life, unsure what to do, and it's got nothing to do with biology. And I think that's where the skills of a good diagnostician and therapist come in, because for people who don't have a genetic vulnerability and are demoralized, discouraged, they need the help of a good therapist to help them discover what's truly important in their lives and to turn away from negative self-talk and rumination, not get rid of it, but turn away from it towards behaviors that build the kind of life that can be meaningful to them. And if this sounds at all familiar, it should. These are the words of Stephen Hayes, Kurt Strassel, and you'll find it in acceptance and commitment therapy.
Yes.
And I think that's an important and profound distinction to make, and a good set of skills to use for people who are not clinically depressed, but are demoralized and discouraged.
Well, that's a good wrap up. I really appreciate that. And I appreciate your participating with me today on Shrink Wrap Radio. So Dr. Brian Quinn, thanks for being my guest. on
Thank
Shrinkrap
you.
Radio.
Thank you very much, so much for having me. I really appreciate it.